Well, good afternoon, everybody. Welcome to SEVA VentRounds. Today is January 13, 2026. This is the first VentRounds of 2026. Unbelievable. And we're going to be talking about waveform artifacts, long, hard, or circuit. What's causing what we see on the screen? There is no endorsement of any mode, ventilator, or manufacturer. Whatever we say, it's our opinion. It does not represent the Cleveland Clinic. I'm Eduardo Mireles. There's my disclosures, and Rob Chatburn, who you see on the screen too. And that's what we do. Remember, keep your microphone muted. You can unmute it whenever you want to give input, but in the meantime, just keep it so that we don't capture background noise. If you want to use the chat function, that's also, we're taking a look at it constantly. And remember, there is CME and CRCE if you're a respiratory therapy, and just complete your evaluation. All righty. This is a key SEVA knowledge. Actually, I would say this is a foundational level knowledge for SEVA and for anybody managing the ventilator, and it's the equation of motion, as many of you recognize. However, I think that what we want to highlight today is to start thinking, and you'll see today the example of what we talk about. What you will see is the equation of motion in action. And let me highlight a couple of items. Whenever we have somebody on mechanical ventilation, the equation of motion tells us that either we control the left side of the equation, so meaning we control the pressure on the ventilator, and so that would be pressure control, right? Or we control the left side and we're controlling volume and flow, and we call that volume control. And that's relevant because we have repeated ad nauseum that when you're in volume control, you look at the pressure, and when you're in pressure control, you look at the flow and the volume. So important features to recognize. However, it's also important to know that changes either in flow, volume, or pressure are influenced by three things, essentially. So when you're looking at the ventilator, the changes are going to be because there's a change in elastance, a change in resistance, or the presence of PMOS. So whenever we look at the ventilator waveform, your brain activity should be, say, looking at what is changing our waveforms, what's the loads. So you know how to read if the load is elastic or the load is resistive, and or if there is presence of PMOS. So just keep this in mind as we look at the this will make sense in 2 seconds as we go into our waveform. But remember, the equation of motion is what tells us what side of the equation you're controlling. So you're controlling, if you're controlling the left side, it's pressure control. If you're controlling the right, it's volume control. And then the patient-determined variables, the elastance, the resistance, and the PMOS are the things that change the waveforms. Rob?
Yeah, that's great. I put in the chat a link to the brief paper that we wrote on the equation of motion.
Excellent. And which is a foundation. That's a brief way of condensing everything that we just said into a nice infographic and paper. And this has to do, and you will see point number 2 essentially talks about that. So let's start by what's the tag. And for our team online, if you want to write it on your chat, what is the tag? Again, this is a Servo U ventilator from Gettinge. Again, we don't endorse anything. It's just so that if you're using the Vent Mode Map app, you can find it. But we put everything here. So if you want to type it in your chat, have no fear. There we go. The team starts pouring in. And yeah, this would fall into what we recognize as volume control, CMBS. But let's analyze a little bit about this, because this is not a common type of waveform, and there's little abnormalities that tell you that this is not that this is volume control, and things that take you a little bit off kilt. And so let's go. The first one is obviously the ventilator says volume control, but as you have learned, the name of the ventilator gives means nothing. That's why we use the taxonomy. And if things would be perfect, there would be a little parenthesis here that would say BC CMBS, like that. Actually, I'm going to start doing that to see if eventually somebody it catches on, and we the manufacturer started doing that, because then we know that this is truly volume control. The other one that some of you may catch is that also there's a tidal volume set down here, but we recognize that that also is not trustworthy, because there's modes that you set a target tidal volume. So again, these two things on the screen don't guide you towards it. The third one, so then you have to rely on what you're seeing on the waveforms, and there's certain clues here. The first one is that you have the flow, and the flow is set in a descending pattern. And in this ventilator, it's different than many other ventilators. You can see here that it says flow pattern, and flow pattern stands. Yeah, thank you, Simran. I'm gonna put a little asterisk down here for Simran. Simran has just pointed out why is the fourth breath, which actually I'm gonna call this one the third breath, Simran. Why is the third breath volume lower? So we're gonna get there. So the flow pattern is set as 0, and what that means is that the flow will decay to 0 flow. And this system has set it arbitrarily to 100, all the way to the top, which is 100% of the peak flow, all the way to 0, which is 0% of the peak flow. And that's a setting, and so the flow is gonna decay linearly all the way to 0. Now, you will argue with me, and we have said that whenever you're controlling volume, you should have a geometric shape, and it should be perfectly shaped. And you can see irregularities here. And I have to be frank with you, the first time I saw that on this ventilator, I thought that I was being sabotaged, that there was absolute sabotage, that the ventilator was selling me volume control for pressure control. And that happens, right, Rob? There's ventilators that tell you that they're controlling the flow, but in reality, they are just manipulating pressure to give you a waveform to look like that. Am I correct or not, Rob?
Absolutely.
So we had a meeting with the engineers, and the engineers explained to us that no, that actually the flow was being controlled perfectly. And if you turned up what they called circuit or tube circuit compensation, that you could see the real waveform, but that this was because there was evidence of other things going on, that this was how it would look if a sensor was in the Y of the ventilator. And that's not on the manual, that to my knowledge, and Rob, you can, or maybe it is, but it's hidden in there. But it was the first time that we heard it, and lo and behold, when we turned off the circuit compensation, we saw it, and it's truly that. And if you put it on a simulator, it's truly volume control. So this is relevant because sometimes you're gonna see those kind of irregular, and so you have to rely on a couple of other features that will tell you that. One is that the volume is identical between these two, and I'll talk about the third one at the end of today. And then fourth is that if this was pressure control, the pressure should continue, and it should not be dropping as much as it's dropping right here. So we'll come back to it, but lo and behold, that's the importance of having the taxonomy, because that helps you if you don't have that level of knowledge of the circuit compensation X, Y, and Z, that this is definitely volume control. The other one, and this is a lateral secret, is that in this ventilator, the dual targeting or flow adaptation does not work when you modify the flow pattern. So if the flow pattern is not 100%, this cannot be dual. It becomes definitely volume control. Rob, comments?
Just another way of saying that is that the flow adaptation only happens with a constant inspiratory flow setting. And
Excellent.
anytime you put the flow pattern, change that, then it's not constant anymore. It's some form of descending ramp. It could be any kind of thing that you want for reasons that I don't really understand. But another thing to point out is those red arrows on the flow waveform show distortions in the positive direction, right? Positive flow, and that's being caused by looking up on the pressure waveform. You see that there's some interference there from PMUS. So essentially what the graphic is showing you is what would happen, what you would see if you had a flow meter at the airway opening. The patient breathes in, they don't get any more flow from the ventilator, but they suck a little bit out of the circuit because it's compliant. There's a circuit compliance.
Excellent. So now that you know that, so Rob has helped us disclose that there was PMOS during the inspiration. So now that you know that, Simran, why do you think the volume is a little bit lower where the asterisk is? Or it's not only Simran, any hypothesis here from the team?
Was there a change in like the something in the circuit that affected
so
the
that's
sensor?
because there's no more PMOS. Now this is the actual volume that the ventilator was delivering. So in the other one, you're sucking a little bit, and you have been at the bedside, and you can see how the circuit distends and then it collapses. So in this case, it's collapsing more when there's PMOS. It's sucking out from the circuit more than it can. So this is a passive breath.
But even so, I thought in volume control, even if there is PMOS, the ventilator will still cut off at that tidal volume.
Well, it doesn't cut off, it just delivers that given flow. What you're seeing here, those changes are the result of the circuit, not from the ventilator giving it. Rob?
Yeah, the ventilator will shut off at the ventilator after it delivers, let's say 300 mLs, corrected for BTPS. But when the flow, the patient can always get a little bit more flow and volume by sucking the gas that's stored in the compressible volume of the patient circuit, right? So adult patient circuits have a compliance of something like, 2, 3, or 4 mLs per centimeter water pressure. And if the PMUS is, 10, something big, then you multiply 10 by 3 and you get 30 mLs you can suck out of the circuit. And that's about what we're seeing here, something like that, right?
That's correct. Wonderful. Thank you, Rob. So I think a teaching point here is use the ventilator mode map to know exactly what your ventilator does. Read your manuals. But these are key clues that will help you. I mean, nothing to do about these variances except the knowledge that there is PMOS. So that takes us to what is the load, elastic, resistive, or PMOS during inspiration. So yeah, now you've heard the whole discussion, but it's PMOS, right? So during inspiration. Now I'm gonna flip it a little bit and ask you, what, besides the fact that Rob said that this was PMOS, what key features tells you that this is PMOS? What items tell you that this is PMOS? Look at the waveforms and write down not a linear decay. I don't know what that means. Fernando, you want to explain a little bit more?
The fact that you don't see a perfect geometric decay of the inspector waveform, I mean, that you see some deformity of the waveform I mean, upwards, that's what can let you think that there's some activity there, there's some PMOS.
Yeah. So the way that I like to think about this, this can help you. So always imagine how would this look if it was passive. So there's the initial straight, the flow goes up so that you can see the way up. And then suddenly you see the drop in pressure. And if this was a passive breath, this probably would look something like that, right? Now, if you see breath number 1, breath number 2, and breath number 3, are those similar? No, not at all, right? So you can see that they are different. So remember what we said with the equation of motion, and this is an important knowledge. So now you have here how it should look. And I'm gonna just humor me for a second, okay? Just as the fellows and team that are listening. So for a second, pause your brain activity and think about the following. The waveform in number 1, the peak looks higher and then the end pressure is lower, okay? And right now we know that this is because of PMOS, but just for a second, imagine that there is no PMOS. What would be the cause of there being a higher peak at the beginning and lower at the end? What would be different? What would be high? What would be the load? Elastance, resistance? There you go, resistance, right? So it would be, if I only had the first waveform and I didn't know better, I would say, and I saw that this is a descending ramp, I would say this patient has an increased resistance. If I don't know better, okay, and I cannot see the patient, I would say this patient has increased resistance. Look at breath number 2. It would be elastic load or resistive, not knowing that the patient has PMOS. This would be, again, higher peak and lower baseline. So you see the peak is here, the next one is over here. Peak is here, this one is all the way down here. That would be resistive load, correct? All righty. Now look at the third breath, here and here. What's the load? Yeah, so it's more elastic, right? It's more. So when you have, so it looks like resistive, worse resistive load, and then suddenly elastic. So unless something is causing in this patient changes on the resistive load from breath to breath, the most common cause for that has to be, there's only 3 options. There you go, Karsten. PMOS, perfect. So now you know when you're looking at waveforms, it can only be the waveform, you're looking for the load, elastic, resistive, or PMOS. If the elastic load is changing from breath to breath, or the resistive load is changing from breath to breath, then there has to be some PMOS. There has to be some PMOS, because that's the only thing that will change breath to breath, unless the patient is biting the tube, but that's a type of PMOS. It's the jaw PMOS biting on the tube and causing the resistance. I mean, and you can think about odd causes, like perhaps there's a mass that it's moving back and forth on the airway. That could happen. I could see, and that would be a cool case for VentRounds. But in general, if you see a difference between breath 1, breath 2, and breath 3, that has to be PMOS. Excellent. Rob?
I want to refer back to your first slide where you showed the equation of motion. And if you can think in your head on the equation of motion, we have 2 terms on the right. The first is the elastic load, and the second is the resistive load. And when you have a descending ramp waveform, at the beginning of the breath, you have 0 volume, but you have a lot of flow. So all you have is resistive load, right there. At the end of the breath, because it's set for 0, the flow to be 0 at the end of the breath. Then flow is 0, so R times 0 is 0, but you have a full tidal volume. So all you have left is the elastic load. So the pressure waveform will start off with a high jump up, and then it'll be curvy in the middle, and at the end, it'll be some other pressure. So that is essentially plateau pressure at the end and resistive pressure at the beginning, or elastic load and resistive load. So that is one sort of side benefit of setting the ventilator with the descending ramp flow where it goes down to 0. I don't know how many other benefits there are, but that's one in terms of waveform interpretation.
Excellent. My God, we're squeezing this orange so well. All right. Very good. So now you know that there's PMOS. Now, what's the load during exhalation?
Small room, so
Fernando, you have to be more specific. Normal is a standard deviation that is huge. Is it elastic, resistive, or PMOS?
I mean, it's difficult to say. Seems that there's some PMAS, but maybe not sure. Maybe, I don't know. That's a good question.
So what's the normal load? I mean, in all of us humans, what's our normal load? Elastic or resistive? What's the main expiratory load? Yeah, elastic, my friends. So remember, we have very so when you say normal, I presume that you refer to elastic, and it's the time, and you can see it's coming back to baseline from here. Actually, fell in 1 second, all the way to here in around 1.5, more than 1.5 seconds. So this is consistent with elastic load. Perfect. All righty. So now for the PV discordance. Let's start with the trigger. Is it normal, early, late, false, or failed? Excellent. So this is a great. So remember, when there's so who triggered the breaths? Breaths 1, 2, and 3. Is it triggered by the patient or the machine? The machine. Excellent. Machine, right? So the ventilator by time. We set the rate at 24, and the patient is breathing at 24. Every breath is triggered by the machine. And I know that because there is no marker that this was triggered by the patient. And the ventilator is the one that knows the truth. It says, oh, this was a patient signal. Or if it doesn't put any change in color, or every ventilator has different markers. Now, if it's machine and then there is evidence of PMOS, as we discussed, then this becomes excellent, Megan, an early trigger. Yes. So this is a great example of a couple of early triggers occurring right here. Very good. Very good. Love it. All righty. So now that we're there, so we have an early trigger. That's the main item on this, the main discordance. And I would ask the team to see if anybody, is there anything else that's bothering you on this? And then we'll get to how we're going to treat it. But anybody has anything else that bothers you on this waveform? Anything that you want to comment? I remember, I think that it was Jorge that put something out there. Anybody? Anything else bothers you? Yeah, thank you. Bumpy expiratory phase. So I want you to pay attention on to the expiratory phase, and you're gonna see this, and I'm putting arrows right now. Actually, let me erase so that everybody can see it because this is getting crowded. Okay, so let's erase. Witchy, 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 witchy. There you go. Much nicer. Okay. So now that we have erased all this nonsense, let's draw the things that I'm seeing for you. So you can see here, 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 and here. There's one last one. So what are your thoughts there? What's causing that? And just so that you get excited about it, I'm going to show you. This is the next waveform. This is the same patient. You can see your early trigger, and now the early trigger is very evident, right? You see the varying heights of, but it's definitely an early trigger. But here are the little humpity dumps that you see. So what's causing this? Have no fear, put the cause. All right, so we have Jorge with one hypothesis. So one of the hypotheses was cardiac. Two for cardiac. Okay, keep going. Any other hypothesis for cause? Anybody else? Cardiac? Is that where we're staying? All right. It seems that everybody supports cardiac. So do think the following. Whenever we have oscillations on the airway, like these ones, it can be cardiac or it can be fluid in the circuit. Yeah, Karsten puts fluid in the circuit. Or it can be secretions, sometimes in the ET tube or in the airway. It can also be excessive dynamic collapse of the airway, so excessive dynamic collapse, and we see that in tracheomalacia and whatnot. And each one of them has different behaviors. So let's try to dissect which one of these is. So I'm going to go to the first waveform. So you can see that at the beginning, they go 1, 2, 3, and then there's a tiny one here, and then they disappear. 1, 2, 3, 4, and then it disappears. However, in the next one, we again see them 1, 2, 3, and then 4. But you see how they're going down in size, like this one over here: high, lower, lower, disappears, high. That's one of the features. So see the difference in height as how it goes down. The second, look at the frequency, and if you consider this to be a second, so from here it starts 1 second, and here finishes a full second. 1, 2, 3, 4, 4 in a second. So that means that in 10 seconds it's 40. In 10 seconds is 40. And that multiply that for times 6, and it's a lot, 240. So it's going very fast, right? For this patient. So the frequency is high, so high frequency, and it goes down with time. And this is relevant. So I want you and this is not by any means a rule forever, but it's important features to recognize. So as this goes down, the oscillations goes down, this is related to the decrease in flow. And as the flow goes down, these oscillations are going down. Does that inclines you to any of these 4 causes? 1, 2, 3, or 4. So now that I have told you high frequency, very high frequency, and they decrease with a decrease in flow, does that make you more inclined towards 1, 2, 3, or 4? So usually so as you start looking at this, if the flow goes down, imagine that you have just like waves in the sea. The higher the sea, the higher the waves, and then if there's no wind, there's no waves. So the same thing happens with fluid in the circuit or secretions. If there's no flow, there will be no waveforms. So that's highly relevant. So if you see that they're decreasing as the flow goes down, that makes you more suspicion for either 2 or 3. 4, which is excessive dynamic collapse, usually goes high frequency and then it disappears because the airway completely collapses and they disappear. And cardiac, they maintain themselves. So in this case, for this patient, it was fluid in the circuit in which we suctioned actually, this was not even suctioned. And I have to admit that I made an error, and Sherry pointed out to me, and she's going to tell us how to deal with this. But I inclined, there was a puddle of water on the expiratory limb, or the inspiratory limb, sorry, just after the humidifier, and I lifted up, and the fluid fell into the chamber, which is a no-no. And Sherry, do you want to explain what I did wrong there, please? But you can see that they disappeared completely. So it was definitely fluid in the chamber. So go ahead, Sherry.
The fluid that's in the circuit is contaminated because you don't know if it came from secretions from the ET tube back out down into the inspiratory limb. So you're not supposed to drain it back down into the humidifier. Best way to take it to get it out of the circuit would be to disconnect the patient and put the tubing into like a chucks or something to catch that fluid. But the patient's on 17 of PEEP, so that's probably a bad idea. So I probably would have done the same thing.
Thank you, Sherry. And so I thought that was very useful. I put this is not the same patient. This is a different patient, but just so that you can see the cardiac oscillations through time. And you can see how the frequency is lower, and this is amplified, granted, but you can see how they persist through the cycle, and the oscillations here, they decrease on the airway side because the flow goes down, but there was also other reasons on this patient, which we'll present in another VentRounds. So to recap, we had a lot of learning on this VentRounds. We talked about the equation of motion, and that helps you recognize that there's only 3 things that can affect your waveforms. It's either the resistance, the compliance, or PMOS. And what you learned today is that if there is changes between consecutive breaths, this is likely to be PMOS. So if it's one after the other and there's changes on the waveform, this is likely to be PMOS. The other one we talked about was early trigger. I mean, we recognize again early trigger on the ventilator. The variant in this case is reverse trigger, and what we did for this patient was to decrease the respiratory rate, just in the sake of time. And the last one is that remember that when you see aberrancies in the expiratory phase that look like there's 4 potential etiologies, probably there's more, but it's either cardiac oscillations, which tend to persist throughout, and they are at a lower rate, unless the patient obviously is going at that fast rate. Cardiac oscillations, and these are very common to see. There's also fluid in the circuit, which is the case that we saw here, and as well as secretions in the airway or in the ET tube. And both of them, the oscillations disappear when you stop the flow, which is not what happens when you have cardiac oscillations. And finally, excessive airway collapse, in which you usually have high frequency oscillations and then they stop. And I think that we've had a case here on VentRounds, but we should put one more. Questions from the team or anger management?
Eduardo, these fluid oscillations could possibly cause false triggering, right?
Absolutely, which was not the case here
No.
because there was nothing triggered by the ventilator, but sorry, by the patient, if that would be a false trigger. But absolutely, Rob, cardiac oscillation, all of these four that we put there are good causes of false trigger. Here's the CME register. Watch the prior episodes. We're at 104. So this is episode 104. And remember, if you have not registered already, register for the SEVA Summit. It's going to be fun. Rob, any other comments?
No, that's great. Good to see you
All
all.
right. I hope that you learned as much. I know it's a lot, but this will be for you to dissect also on the webinar. If you have more questions, please send them to us. We're happy to interact. Have a great day, my friends. Bye-bye.